name's Jonathan Iredell and I'm a Professor of Medicine at the University of Sydney and Infectious Disease Physician and Microbiologist at Westmead Hospital in Sydney. So it means looking after severe infections and unusual infections. So when we're rostered on, we will typically manage inpatients, that is to say people who present with undifferentiated nasty infections that we will look after as our primary responsibility. And we will look after patients who are in the hospital under other specialties. They might have had a car accident and subsequently got an infection. They might have had a transplant and subsequently got an infection, and we'll be asked to give expert advice on that particular aspect of their care. So they're the two dominating agendas. For those of us who also work in a laboratory environment, the same is true there. You are regularly visiting the laboratory, interacting with the laboratory scientists, your colleagues who work on the benches there to diagnose infections. Infectious diseases particularly attracted me because of its depth and breadth, and because it's one of those disciplines where you really can just fix someone. I think mostly at the moment we're using it to understand relatedness. I mean, the contemporary example would be the current pandemic we're experiencing, where we want to understand whether somebody caught the virus from someone else. We can look at the genome of the virus, its genetic fingerprint, and compare them. So we understand the pathogens better, we understand their transmission better, and we can identify them more efficiently. So it's broad and diverse, and for that reason very attractive to many people. You know, you can see someone who you know that you have the expertise required to literally save a life, and that it is not likely to be a chronic recurring problem from which they won't recover, but it's a true fix. Best part of my work as an infectious diseases physician? Well, there's lots of good things. I think I really enjoy being able to resolve a problem quickly with expertise that I can only bring to it, so you feel like you're contributing something. And I love doing that in multidisciplinary teams where you're bringing everybody together and everyone's contributing something and you've all solved the problem. So many of us do our training in infectious diseases and microbiology, but also do science training as well. So you're about 7 years after you're graduated from medical school when you would be finished your primary training as an infectious diseases specialist. Infectious diseases physicians and microbiologists always work closely together, and often they're the same person, and now our training systems are pretty closely intertwined. I think at the moment the use of genomics and genetics in clinical medicine does not necessarily require a deep research training. It's just at the moment the most available training. We need to move to a specialised professional training system in genomics, and we're working hard at that at the moment. And I think as we get more precise with tools like the genomic tools that we have coming, we will be able to do that better and faster. Genetics is reference to a gene that might be causing a problem that you might have inherited. Genomics is in reference to all of the genes. Look, the great thing about working for a big state organisation, the State Health Department, New South Wales Health, is that you're working in the public sector at the pointy end of all the most serious diseases where you can make the most impact. So I think the things that I most enjoy as an infectious disease specialist in a big hospital environment is the interaction with the trainees who are coming up. I love being able to recognise a difficult problem and fix it. So the exciting thing about the future, I think, is that the tools that we now have, that we call the genomic tools, enable us to move to a much more proactive management of infectious diseases and microbiology than we'd ever been able to.